Hey everyone, this is Ike Ahmed from Prism Eye Institute in Canada and John Moran Eye Center, University of Utah. I'm here to share a few pearls on one of my favorite topics, which is phacoemulsification, digging deeper, talking about the essentials of optimizing fluidics and also power delivery. So as we know in phaco, of course, we're working in a closed system in an anterior chamber, and the main goal of phaco is to remove nuclear and cortical material. That means we have to aspirate and remove that, and to replace that, of course, we need irrigation. So it's this balance between irrigation and aspiration, which is important in maintaining that closed system environment. This means we have to have adequate irrigation and match the parameters of vacuum and flow, which we'll speak about shortly. Of course, we also have to combine that with phaco, which we'll speak about that shortly again as well. Now, when it comes to providing infusion into the eye, historically, we use gravity-based systems, which basically means we have a bottle at a certain height. The infusion comes in at a certain level to ensure we have enough pressurization in the eye. Now, usually we would over-pressurize the eye because the problem with, of course, phaco is we may remove pieces, but once we build occlusion, we may get surge. Now, surge is something we're all very familiar with as cataract surgeons. This is a sudden collapse of the anterior chamber or loss of pressure in the anterior chamber because of loss of volume. Typically happens after occlusion, after a nuclear piece is aspirated from the tip after occlusion. There's a sudden collapse of the tubing. This results in a sudden rush of fluid into the system and a loss of pressurization. To account for that, we've set the pre-op bottle height at a high level to account for that loss of pressure. That's gravity-fed conventional systems. Now, modern generation machines now are able to compensate that in a more readily and a faster method by using active fluidics. What we mean by that is we can actually actively infuse in the eye as the chamber of environment is evolving. And this can be done by pressurized systems or plate squeeze systems where bags are basically compressed to provide fluid flow into the eye. And this really provides an advantage to allow us to work at a lower pressure, for example, to have more dynamic response to changes in the intraocular environment. And now we have the ability to have sensors closer to the eye, even in handpieces, that allow us to pick up changes in the IOP dynamically to allow us to compensate. Machines also have a system called venting. Venting allows us to put fluid into the aspiration line to prevent collapse of that aspiration line and a sudden rush of fluid. So this basically allows us to use both systems to essentially compensate from the loss of pressurization from surge. Now, when it comes with methodology in terms of fluidics, we have two predominant systems in employment in both the anterior segment and posterior segment. There are peristaltic systems and Venturi systems, and nowadays we have systems that actually combine both or allow the user to choose one or the other during the phaco procedure. It's important to understand the differences between these systems, again, between peristaltic and Venturi-based systems. Now, very much a way to think about this is think of flow-based systems and vacuum-based systems. Peristaltic systems are essentially flow-based systems. What this means is basically these systems comprise of roller wheels that compress the tubing to create flow. This flow creates a certain flow within the tubing and within the eye to extract fluid and material from the eye into the phaco machine. Now, this basically allows us to then bring material to the tip. Vacuum is only built when occlusion occurs. And so when occlusion occurs, the roller wheels still continue to roll. This builds up essentially pressure within the vacuum within the system. The tubing actually then ends up expanding and basically then builds up vacuum, allowing us to hold material to the tip. Some of the benefits of this system, it allows us to control flow and also maximum vacuum. So there are two settings we use here: what the flow rate is and how we can control it. Linear, for example, in terms of building up as our foot pedal goes down, and what the maximum vacuum we achieve when we get occlusion. So this allows us to have a bit more control, controlling two variables in the fluidic system: your flow rate and your vacuum separately. Remember, we only get vacuum when we get occlusion. So in some ways, the systems can be a little slower, and perhaps for some people argue maybe less efficient in terms of bringing material to the tip. On the other hand, vacuum-based pump or Venturi systems don't create vacuum by flow. They create vacuum within the rigid cassette. This creates basically vacuum and creates flow in that example here. So therefore, basically, vacuum can be controlled, and flow occurs dependent on the vacuum. So there's no separate setting necessarily for a flow rate here as well. Because of this, we have control of vacuum. Many would argue that because of this, we don't need to reach occlusion to generate vacuum and into the eye and bring material to the tip and evacuate it. In some ways, these systems may be felt to be more responsive, although nowadays systems are fairly similar. Surge control can also be variable as well. Although the vacuum-based systems are very powerful, they may protect us a little bit in terms of not by decoupling the flow and vacuum control within the systems. Both can be used. Personally, I think a peristaltic system can be helpful during the maneuvers like, for example, chopping, where we want to occlude the tip and hold pieces, like occlusion mode, phaco. While vacuum-based pumps are particularly helpful for evacuating, for example, cortex, lens material, and of course, many vitrectomy machines are based on vacuum-based pump for those reasons. I'm going to show both the use of peristaltic settings as well as Venturi settings, depending on what part of the phaco I'm doing. Dense cataract, sculpting here, peristaltic works quite well. I don't really need vacuum here. I'm looking more at power delivery here. I'm looking more, of course, at just evacuating the lens material during sculpting. Now, chopping peristaltic is optimized here. I allow my flow rate to build up, reach occlusion, and then build up that vacuum. And occlusion is what I need here to hold the piece so I can chop it and crack it in half. We're going to do our second chop here. And again, I'm staying on peristaltic here with longitudinal phaco to drive the needle in there, hyperpulsed here. We get occlusion as the flow basically allows us to bring the piece to our needle. The vacuum builds up on occlusion, and I make that chop. So really peristaltic, very effective to allowing us to enhance occlusion mode holdability phaco. We're going to hold pieces, allow us to chop them. We're not looking at evacuating them here. But now I need to evacuate the piece. Here's where we're going to move here to a Venturi pump on the same platform. Here is a segment removal. I'm not looking at occlusion here. What I want to achieve is rapid removal of that piece, keeping that piece, following that piece into my tip. And Venturi allows us to do this because we don't need the tip to be occluded to encourage vacuum, and we're using vacuum to encourage flow. So again, segment removal, helpful for Venturi. This just shows the example and the differences between when we look at peristaltic versus a Venturi-based system, how we can go back and forth. And you can see again how efficient the Venturi or the vacuum-based pump is used for segment removal, while when we're looking at holdability, where we're looking at chopping, not evacuating, allowing the vacuum to build up, the flow to build up that vacuum as we occlude, allows us the nice control to hold the piece, allow it to be chopped. Action is much slower, much more controlled, much more about holding pieces and chopping them. Well, let's talk about phaco delivery here. And of course, we have primarily three different methods of phaco delivery: continuous phaco power delivery, as well as pulse mode and burst mode. On top of that, we can also talk about how the power is delivered, whether it's longitudinal in ways, or elliptical, or oscillatory like torsional. And all of these combined provide for efficient phaco. They also allow us to customize how we use those parameters in different ways. Now, historically, with continuous phaco, with linear phaco, this created chatter and thermal injury. And therefore, by pulsing the energy, this reduced chatter by keeping material on the tip and not pushing it away, and also reduced the energy delivery at the wound and reduced thermal injury. Hyperpulsing I find to be very effective when we use longitudinal phaco. And this again helps to allow us to keep things at the tip and also lower the energy delivery to the wound. I like longitudinal phaco particularly, for example, when we are looking at driving the needle into the nucleus, holding the piece, allowing us, for example, to chop a segment. On the other hand, torsional and elliptical phaco, where we basically use more oscillatory motions of the tip, non-necessarily linear technology. These are typically lower frequency and often have less issues around thermal injury and less chatter. In those examples, pulse modes may not be as important, and continuous can be quite effective and quite helpful in terms of evacuating and improving followability. So different modes can be used for different reasons. Burst mode also is another mode folks like to use sometimes, where basically high energy delivery can be placed in burst settings, allowing one to drive the needle into nuclear pieces, particularly dense cataracts. These perhaps have become less commonly used now that we have the ability to use torsional as well as elliptical phaco technologies as well. Finally, we have the ability to combine all these together, where we have both longitudinal and torsional delivery in a pulse fashion. This again combines both technologies in a way that's pulsed. Technologies are further advanced, where now this is all done in one motion, where this is like elliptical, or what's been termed 4D phaco as well in other technologies, where basically all this is done in one motion. Now, when it comes to using these phaco modes, it's helpful to differentiate between sculpt settings, chop settings, and quadrant removal. Now, typically in sculpt settings, these are typically low vacuum, low flow. We're basically grooving and taking small lens material in a sculpting fashion. Typically, these can be used with longitudinal combined with torsional or elliptical phaco to allow us to get efficient phaco cutting, lower energy demands in a sculpting fashion. Now, chop settings are a bit different. In chop settings, we're looking at higher vacuum settings, of course, higher flow settings. In those examples, I find typically that longitudinal pulse phaco allows us to drive the nucleus, drive the needle into the nucleus without creating a larger opening, where oscillatory phaco or torsional phaco can do that, allowing us to get good purchase and good occlusion to lollipop the piece. And by using pulse, we can basically pulse and use efficient energy to drive that needle into that nuclear piece. On the other hand, when we actually chop the piece, or we want to bring a segment into the anterior chamber and evacuate it, now we're moving from holdability, which is optimized with chop settings, to more followability, which is quadrant removal. In that example here, we're not so interested in occlusion. So we actually appreciate and take advantage of torsional phaco, with or without pulsing, to allow us to improve followability and remove those nuclear segments from the anterior chamber. Again, using higher flow rates and moderately high vacuum rates as well. Well, of course, every cataract is different, and our goal as surgeons is to optimize the phaco parameters for a given cataract. For example, the soft cataract will be managed different than a more dense nucleus. In softer cataracts, we have to be careful not to apply too much phaco power, not to cavitate and lose our purchases, and therefore, we typically use lower vacuum levers, lower flow rates, and use more sculpting methods if we need to, or more horizontal chopping techniques for those approaches as well. Dense cataracts particularly are difficult, of course, because it's difficult to get that deep crack. I find often using some sculpting maneuvers first, making a trough, making a deep groove, either doing a stop and chop that can be helpful, and then using our chop techniques, or just doing a good divide and conquer can be helpful for those dense cataracts. Now, particularly in dense cataracts, power modulation is important. We want to reduce the energy. We know that energy delivered into the eye means more corneal endothelial cell loss and corneal trauma. This can be effectively delivered by using more pulsing, longitudinal phaco with lower energy parameters, changing your duty cycle as well to incorporate the right phaco power within each pulse, as well as using more alternate techniques, non-linear phaco, for example, like oscillatory, torsional, and elliptical phaco technologies to allow more proficient evacuation of nuclear material. We usually, of course, need to gauge the amount of phaco delivery for those dense cataracts, and doing multiple cracks, multiple chops are helpful to remove those pieces as well.
Hello, this is David Chang. I'm in private practice in California and a clinical professor at the University of California, San Francisco. And I'm delighted today to be able to share my pearls for using OVD in both routine and complex situations. Well, a cohesive OVD is really good for occupying space, and it also comes out of the eye much easier. So, for example, many surgeons like using it for the capsulotomy step, and definitely to fill the capsular bag for IOL placement, knowing that it'll be much easier to remove the cohesive OVD at the end of the case. On the other hand, it quickly exits the eye when the infusion from the phaco tip is introduced. And so we like to use a dispersive when we want the OV to really stay in the eye and to coat tissues like the endothelium in a case with Fuchs corneal dystrophy or a brunescent cataract. So anytime you want to have it stay in the eye to protect the cornea longer, many surgeons will prefer a dispersive then. And as we'll talk about, it has unique applicability for complex cases and managing complications. There are definitely situations such as more complex cases where I'm more likely to use a dispersive OVD. For example, with a rock-hard nucleus, I'm using the dispersive to assure good protection of the endothelium. Now, you do have to initially aspirate it out before you start sculpting. And what I've done is aspirated the portion right above the lens, because when you do emulsify that brown nucleus with the dispersive, they can mix together and sort of form like a sticky molasses-like glue that will clog your tip and lead to a wound burn. One of the real benefits is to anticipate, either with a dense lens or perhaps zonulopathy, the fact that with no epinucleus and very little cortex, I'm in danger of aspirating the posterior capsule with the phaco tip. I think I'm protecting myself by positioning the chopper right under the phaco tip. I moved it just an instant, and even though I'm really slowing down, I'm concentrating on that piece. Right there, I've aspirated the posterior capsule, and you see a perforation in the posterior capsule. So what should I have done? I should have anticipated that with the zonules being weak, the posterior capsule is just not under its normal centrifugal tension. And so I should have paused and placed, as I'm doing in this case, dispersive OVD in the capsular bag. This not only distances the fragment from the posterior capsule, but it actually fills the capsular bag. And because the dispersive stays where you put it, it's not being aspirated, it actually puts the posterior capsule on stretch. Let's do another case. So again, you have to anticipate with zonulopathy, and also this often happens with these really dense lenses where there's no epinucleus or a very scant epinucleus. The posterior capsule wants to come forward and trampoline like a sail that's not taut toward the phaco tip. So we just want to fill the capsular bag. I'm putting in the dispersive. The dispersive stays put. It isn't all immediately aspirated out under this epinuclear setting. In the same case, try to remove the cortex, and you see the posterior capsule wants to come up to the aspirating tip with the cortex because the zonules, again, are not keeping it taut. There's no counter fixation. So this is very precarious because I'm very much in danger of aspirating the posterior capsule. So look at what happens when I fill the capsular bag with a dispersive OVD, which again stays where you put it. Now it's putting that posterior capsule and the capsular bag on stretch, keeping it back away from the tip. When you're facing a complicated scenario, again, knowledge of how to use OVDs is a critical part of your strategy, and often a dispersive may come to the rescue. I know I have to be careful because it's a posterior polar cataract. So as I am starting to see the posterior capsule, I have to assess, is it possible that there's a split in the posterior capsule? And there might be. So the first thing I do is I reach for a viscoelastic. Now it could be either a cohesive or dispersive. Frankly, you would just grab whatever is available. But if you have it, a dispersive is very nice here. So as you know, I come in through the side port while I'm still on infusion so I don't lose pressure in the anterior chamber. And then I go to position 0 as I inject. And what this does is it maintains pressure in the anterior segment so that vitreous doesn't prolapse through. Now, I like using biaxial INA, but when I come out, I have to pressurize the anterior chamber. If the chamber shallows, vitreous will prolapse through. And here I do have time to make sure I'm using a dispersive. Again, it stays where you put it, so it does a better job of forming a barrier, which in the case of an open posterior capsule, we very much need our OVD to form this partition. And we want to block the prolapse of vitreous from the posterior segment forward. And again, that's why I'm using biaxial INA. Once again, before I remove my irrigation, after taking out the aspiration, I have to inject the dispersive through the side port, and that repressurizes the anterior segment. This again is staying in the retro capsular area. I'm placing a 3-piece IOL in the sulcus, and then I'm going to capture the optic. Now, I'm not going to go and remove that dispersive OVD, but it's going to leak into the posterior segment, and it is a lower molecular weight molecule, so it will be readily absorbed and it won't cause an IOP spike. I certainly will remove the OVD in the anterior chamber. Now, if you suspect a tear in the posterior capsule, you have to have the discipline not to chase or pursue the remaining fragments, knowing that if there is a rent, as you direct the phaco tip posteriorly, the infusion will actually widen the rent and in many cases wash vitreous forward. It will propel the pieces posteriorly, making it more dangerous for you to aspirate lest you incarcerate vitreous. So I have talked about a strategy of using the posterior assisted levitation through a pars plana sclerotomy to sort of reposition those pieces with OVD and then use the viscoelastic cannula to levitate the pieces up into the safety of the anterior chamber. A strategy that I call the viscoelastic trap means that I'm going to actually not just elevate the fragments, but I'm going to fill the entire anterior chamber with dispersive OVD, again realizing that a dispersive will stay where you put it. Now, I can't actually see the invisible transparent vitreous strands, but it doesn't matter because the vitrector is then introduced to the pars plana, and I systematically cover the entire retropupillary area, severing any of these strands. Then the pieces are suspended by the viscoelastic so they don't fall posteriorly during the vitrectomy, allowing me a chance to remove them. So here is a case where I have really brunescent fragments, but I know that I have a posterior capsule rupture, so I introduce OVD. It's a dispersive through the side port. I already was using dispersive because of the need for better endothelial protection. Now here I'm levitating the pieces up. I happen to be using the limbal incisions here, and I'm using the dispersive to maneuver the pieces because, again, it's better at doing that, but also sort of forming a partition to basically trap all of the nuclear material in the anterior segment. I'm making my pars plana sclerotomy, 3 millimeters posterior to the limbus. Here's an MVR blade, and now through the posterior approach, I'm levitating that last little piece up with a cannula. Now, it may not be as easy to appreciate, but my goal is to fill the anterior chamber with dispersive viscoelastic, and then to perform the vitrectomy behind the pupil. There's a side port infusion at the limbus. As I'm doing the vitrectomy, the nuclear fragments don't move because they've been trapped in the anterior chamber with the dispersive. That's what I want. If it wasn't for that, this is the point at which they start to sink posteriorly, and then you lose them into the posterior segment. Now, once we have done that, we have the option now that we've transected any forward prolapsing vitreous strands to, again, remove these pieces by first inserting a 3-piece IOL to act as a scaffold. I use the dispersive to kind of maneuver those pieces to the side to give me room to place the lens. And this technique, popularized by M.R. Agarwal, serves as an artificial posterior capsule. It's a floor that keeps these pieces from descending through the open posterior capsule, but it's also a shield that blocks any vitreous from moving forward into the phaco tip. So what we do now is we position, I'm doing one last pass of the pars plana incision anterior vitrectomy. Again, it's an anterior, not posterior vitrectomy. just to make sure there's no pieces prolapsing. Again, a dispersive stays where you put it, so it's also serving to block vitreous from coming around the edge of the optic forward into the anterior chamber. Then you'll see me removing these last fragments with the phaco tip. I'm using very low vacuum and a low aspiration rate. And again, the beauty of a dispersive is it stays in the eye, which is what we want. So I have no danger of aspirating vitreous, which is the cardinal sin in these situations. The last piece, I'm having trouble lining it up, and it wants to ride over the edge of the IOL. So I have to come out, use my dispersive, reposition it. And again, the dispersive also does a better job of protecting the cornea, given that we are doing essentially anterior chamber phaco with a brunescent nuclear set of nuclear fragments in this case. So there you see how the dispersive has helped me get out of trouble in this situation of a complication.
Hello, my name is Dr. Jennifer Loh, and I'm a board certified ophthalmologist practicing in Miami, Florida, USA. I'm the founder and medical director of Loh Ophthalmology Associates. Today, I will be providing insights on cataract surgery advances, next generation phacoemulsification, and technologies. With the newer technologies, there's a difference in the IOP that's achievable. The AFS, or active fluidics system, uses real-time intraocular pressure monitoring and adjustment during surgery in order to maintain a preset target IOP. This is different from the older traditional gravitational fluidic systems, or GFS. Those systems, as you may remember, used gravity alone in order to control the IOP. So it's a manual adjustment of the irrigation pressure based on the height difference between the BSS bottle and the operated eye. The higher the bottle, you have higher irrigation pressure. But there can also be a delay. So there's that delay from raising the bottle or lowering the bottle. And as we know in cataract surgery, milliseconds count. The AFS uses an automated adjustment based on changes in the IOP. And this allows for better anterior chamber stability. By having a more precise control of the IOP, there's less risk of surge. So again, by having these improved technologies, it's really helped us control the IOP better and even more critically control the anterior chamber depth in a more controlled and improved fashion. By having enhanced safety with the active fluidic system, we have a reduction in post-operative corneal swelling. There's better endothelial cell protection, and there's less incidences of posterior capsular rupture. With the advent of phacoemulsification technologies, we've had improved ultrasound energy delivery modes. Traditionally, there was the continuous delivery mode, which is a constant ultrasound energy delivered with the foot pedal being depressed. However, luckily, technologies have advanced and the engineers have come up with alternative systems such as Pulse, which is an alternating on and off cycle of energy delivery, which allows the tip moments to cool. Burst technology, which is a preset maximum energy burst with intervals. And this is triggered with your foot pedal being depressed. And then we also have even newer technologies called automatic ultrasound modulation. And then this can be seen in certain devices that the ultrasound energy activates upon occlusion and deactivates with no occlusion. And this allows for a more streamlined approach, less manipulation with your foot pedal, and it optimizes energy use for lens emulsification, which is important for postoperative corneal edema and wound healing. Using the intermittent power modes versus continuous can reduce total ultrasound exposure and minimize heat generation. With these newer technologies, we're minimizing that heat distribution to the corneal incision, which is critical. There's also different types of ultrasound direction. We know about longitudinal, torsional, transversal, and these are all tailored to the type of cataract you're removing. Torsional is something that allows us to really use the less energy while at the same time still emulsifying the cataract. I find that longitudinal energy can be helpful in those denser cataracts as well. There's also different types of ways we can break up the cataract as surgeons. Traditionally, there's always been the divide and conquer technique that we're taught usually in training, but there's also other techniques like the phaco chop technique, which just by strategically breaking up the cataract using our instruments, we can minimize ultrasound energy to help, again, reduce that risk of tissue damage and preserve endothelial cells and reduce corneal edema. There's been advancements in phaco tip design, such as improving the bevel angles, which allows for increased cutting efficiency. And then even more advanced, we have devices on the market now that allow for an ultrasound-free lens removal. In cataract surgery, we are looking for those smaller incisions. Traditionally, we've used 2.8 to 3.2 for conventional phacoemulsification, which was still an improvement from the past when we did those larger 5 to 8 millimeter extracapsular incisions. But now we're moving into a world of ultra small incisions that can be between 1.8 to 2.2 millimeters. Having a smaller corneal incision minimizes corneal trauma and assists with faster recovery. Of course, having small incisions, we do need to have an IOL that's foldable and that can fit through the incisions. But luckily, we do have this technology at our disposal. What are some other options too for breaking up the cataracts? Well, we also have a new device on the market. It's a micro interventional lens prefragmentation wire loop device. And this loop is a novel design. It's flexible, it's soft, it doesn't disrupt the posterior capsule, and it's able to actually wrap around the cataract and then slowly divide the lens nucleus. So the rationale for prefragmentation using mechanical chopping or flax is really that it requires less energy versus cataract surgery. The goal is to really ultimately reduce postoperative swelling, reduce postoperative corneal edema, and allow patients to get a quicker visual recovery. So all of our technologies and our advanced techniques have been working towards this. So when you think about the benefits versus the limitations of each different section, we have the pre-fragmentation, the micro-interventional lens pre-fragmentation, and this helps with reducing capsular trauma, reducing total phaco and irrigation time, and then it's very, very useful for dense brunescent cataracts. It's helped me, at least in my practice, reduce the need for extracapsular technique as much as in the past, and provided patients with a quicker recovery when they have those dense cataracts. However, things to note about it. I will say that it may not be the best for patients that have a zonular weakness. Then there's femtosecond laser prefragmentation. We also know that this helps reduce phaco energy and reduce the time. It enhances safety, helps with softening the nucleus ahead of time, and also is helpful in dense nuclear cataracts. Pre-chopping, again, also reduces phaco time and energy, reduces endothelial cell loss. However, it can be difficult in those harder cataracts or anyone that has a weak zonule. And if you're not as familiar with it, there could be a increased risk of posterior capsular rupture. Rotary chop is great as well, also by helping reduce the phaco time and energy, good for dense cataracts, but there is that steeper learning curve if you are not familiar with it. That could be one limitation. Divide and conquer is the most probably commonly taught to surgeons in training. It's also suited for soft cataracts, but some downsides can be there. There's a little more phaco energy required, especially in some situations like a denser cataract, and maybe less efficient for those hard nuclei. Also recently discussed has been this concept of non-chopping rotation with a laser. And this is sort of like a rotational technique of removing the cataract. This can be very good with soft cataracts. Soft cataracts, as we know, don't chop very well. They're hard. They're actually difficult to break apart because they're so soft. For us surgeons, we like the fact that it helps customization of the diameter of the capsulorhexis or the capsulotomy. It allows for better centration. We can actually use the imaging of the femtosecond laser device to center the capsulotomy where we want it to be, which we know, especially in premium implants, this can allow for better functioning of the implant. It can also help for patients that do have weak zonules. There are some issues, though. You do have some. There can be some patients that possibly have an anatomical characteristic, such as a deep set globe, that could affect docking feasibility, and the patient does have to be able to cooperate. The lens fragmentation of the femtosecond laser is wonderful as well. It allows, you can actually customize the pattern of the fragmentation that you like to minimize thermal stress or allow for that non-rotational phaco removal like we discussed earlier. And by lowering the phaco energy, we could be providing a protective effect in corneal degenerative diseases such as Fuchs. And again, having this opportunity to allow for fragmentation of a dense cataract can be good. One thing, if the cataract is very dense, such as a dense brunescent or a white cataract, there can be some difficulty in analyzing or imaging the posterior capsule, and that could force you to have a less deep fragmentation of the nucleus in order to be cautious. But it can still provide some help, even if the cataract is not able to be imaged precisely, but you do have to exercise caution in not going too deep with your laser fragmentation. And then another valid reason to use femtosecond technology is the corneal incisions and the arcuate incisions that we could create with femtosecond laser. That is another primary use of femtosecond laser, is to help with astigmatism reduction of corneal astigmatism. We know on the market that there are more and more cataract phacoemulsification machines being released, including the Alcon Unity, Alcon Centurion, Bausch & Lomb Stellaris Elite, Johnson & Johnson Vision Veritas, Zeiss Quaterra 700, Oertli Cataracts, Eva Nexus system, and also the MyCore device, which is not actually a phacoemulsification device, but it does remove cataract, the nuclear cataract using a non-thermal technique. And these, what do these new advances include? Well, these new technologies, these new devices, they're giving us real-time intelligent fluidics, which, as discussed earlier, helps control that anterior chamber stability, reduce that post-occlusion surge. There's novel pump technology, again, giving us that better anterior chamber stability. There's advanced energy modulation, which is allowing us to have better control of that postoperative inflammation and corneal edema. There's ergonomic improvements in the handpiece, advanced tubing. And again, there's also these newer non-ultrasonic lens extraction techniques that are coming to the market. On another vein, what about surgical planning? Well, we have many more systems now that are actually AI or artificial intelligence driven, and that actually help us plan surgically for the outcome. There's robotic assisted cataract surgery that is possibly coming, will probably be coming to our world at some point, and that would allow real-time integration with imaging platforms, possibly improve surgical productivity and precision guided robotic assist systems.